Thanks for joining us for this symposium. I'm Bill Rapisi, President and CEO of the Lymphatic Education Research Network. LE&RN's mission is to fight lymphatic diseases through education, research, and advocacy. In order to win a fight, you first have to join it. So we ask, please become a supporting member of LE&RN at lymphaticnetwork.org. And we hope you enjoy today's symposium.
Well, welcome everybody who's online following us today or watching this today. My name is Roman Skoracki. I'm one of the plastic surgeons at The Ohio State University. And with me is Brittany Knauss, one of our lymphedema certified therapists who has a very special interest also in head and neck lymphedema. And the topic today we've been invited by LE&RN to speak about is head and neck lymphedema and its management. We're excited to be here. We're excited to be working with LE&RN as always. What an incredible organization. We are very proud to be a center of excellence through the LE&RN network, and obviously extremely engaged and love to spread the word about lymphedema and share any knowledge that we can. So without further ado, I'm going to wait until the important disclaimer is run through, and then I will hand it over to Brittany to give us an introduction to lymphedema, some conservative management strategies, and a case presentation. Thank you, Brittany.
Yeah. Good morning, everyone. So I've just put together a presentation. I'll mostly focus on a case loosely based on a patient that Dr. Skoracki and I had shared in the past. So I'm going to talk about complete decongestive therapy and what I did for this patient. And then eventually I requested a referral to plastics, and that's where Dr. Skoracki steps in. So these are our objectives. So we're really going to understand lymphedema a little bit better with the head and neck cancer patients, and then understand how our multidisciplinary team works together to put together an appropriate treatment plan for these patients. So this is just a few housekeeping slides to make sure we're all on the same page. I know a lot of you are already familiar with lymphedema since you're attending our talk today, but this is the definition of what lymphedema is, and then I think it's always important to remember the difference between edema and lymphedema specifically. So edema is acute and has low protein. Lymphedema always has that high protein content, and that's really what distinguishes it. So for head and neck cancer, there are about 600 to 700 lymph nodes in your body. So that's a lot, but one of the area that there's a lot of an accumulation of lymph nodes are in this head and neck region. So there's about 100 to 200 in the abdomen, and then the second most amount comes in that head and neck area. So this is why a lot of our patients are affected with lymphedema. And then this next slide will kind of show that incidence of lymphedema. So in the head and neck cancer patient, a lot of patients have the mixed lymphedema. So they have both internal and external lymphedema. So in one of the studies I found, it had like 81 patients, and 61 of 81 patients had some form of that late effect lymphedema. So 9% of them had only external, and 40% had only internal, but 50% of the patients ended up with both internal and external lymphedema. So that's why it's so important with these head and neck cancer patients, because in that study, 75% had some form of lymphedema, but as we were talking prior, we've heard 80 to 90%. So it just depends on your study. So sometimes that's increasing. So to kind of talk about what I did with this patient here, this is the background of the patient. So this is their surgical history. They had a right composite resection and mandibulectomy, right neck dissection. So lots of lymph nodes removed, and then also a history of radiation. So both the lymph node removal and the radiation history increased that patient's incidence for lymphedema. So radiation finished in about June, and they got a referral for lymphedema therapy placed in September. So about like a 3-month lag period before they started seeing us. So when I evaluate these patients for rehab purposes, this is kind of what I do. We really want to make sure that the evaluation is comprehensive because these patients have extensive surgery. It doesn't need to be complex. And one of the really most important things that I find is the subjective evaluation, because this gives you a really good picture of their swelling and what has been done so far for it. So I always like to note what other disciplines they're seeing. So a lot of my patients are also seeing speech therapy. So we work really close with the SLP team here. I know in some centers, SLPs do lymphedema treatment, but here our physical therapists do it. So really making sure I have a collaborative relationship with the speech therapist is important. Understanding what their treatment course has been and if there's what their plans are for the future. A lot of times this patient had been done with all of his head and neck treatment, so he was kind of on just seeing me at this point in time. So I like to know what they've done in the past to treat swelling or lymphedema, kind of the timeline of when it starts, and if there's any patterns, like what makes it better and what makes it worse. I also make sure to ask them about numbness, tightness, anything else that might be going on. So I try to get a good picture of what's happening with them. So these are some of the objective measures that I make sure to take. So posture is really important. A lot of times, a lot of these patients come in with this forward head posture, and if I can help get them sitting up straighter, that opens up their lymphatics and helps with drainage. So not all of my treatment is CDT components. A lot of postural education helps what I'm doing with complete decongestive therapy as well. So these are 2 scales used for head and neck lymphedema to kind of rate how much they're having. So the FOLD scale was developed for limbs specifically, and the MDAC was not validated, but it is helpful for these head and neck patients to be able to classify where you feel like their lymphedema is. So these are a lot of the lymphedema measurements that I do and that are common in the literature. So with the superior measurement, it's immediately below the mandible. The inferior is the lowest circumference, and then middle is somewhere in between. These are the facial measurements that are done. And then a lot of times we're looking for a 2% change to be clinically significant. One thing that is important to note is to monitor their overall weight, because if they're gaining weight, sometimes that changes some of those measurements a little. If you don't have that 2% change present, there are other indicators such as changes in the firmness or visual changes as well. So how do we track some of these changes besides just our measurements? So photography is used a lot to kind of keep track of those head and neck changes. So some of the things with taking pictures is you need to make sure that you as the photographer are setting up the scene the exact same way in order to see those changes. So make sure the distance is the same, they're sitting at the same height, you're sitting at the same height, so you can really get that consistent angle, and those can be meaningful throughout your treatment if needed. 3D imaging, so there are some programs that are being developed to try to monitor some of these changes. So I think that will definitely be the future of tracking this head and neck swelling over time. Outcome tools, so there are no outcome tools that I use that are validated for head and neck lymphedema specifically, but these two, the NDII and the University of Washington Quality of Life Index, have been validated for shoulder dysfunction with head and neck cancer patients. So that was in the last 2 or 3 years. So hopefully something for lymphedema will be coming. Okay, so what did I do with this patient specifically? So remember, he had a history of neck dissection and radiation as well. So we did most of the components of complete decongestive therapy. So talked about taking really good care of his skin, keeping it well moisturized. We did the exercises, the manual lymphatic drainage, and talked about compression use. So this is when I go over skincare, I really make sure that they protect their skin from the sun, they wash it with soap and water, continue to apply lotion after radiation. And then I try to have them try to monitor the swelling patterns throughout the day. So a lot of times with these patients, when they sleep overnight, they're laying flat, so they tend to get more full. And then throughout the day when they're upright, gravity can help some of that drain. So they're looking the best at night. So I try to have them pay attention to their own swelling patterns so they can help best manage. So these are some of the lymph drainage exercises I do. So diaphragmatic breathing, some gentle isometrics with the neck and the shoulders. And then if they're having facial swelling, I'll add some facial exercises to it to help those facial muscles move some of that fluid out. So for manual lymphatic drainage of the head and neck, the biggest considerations that are different between other limbs are drainage pathway based on history of radiation or surgical history. So this is the anterior pathway. You want to push the fluid down. So you want to clear the trunk and then come straight down. So this pathway that we would do would be used for if they only have a history of radiation, because then we don't need to go around the surgical scar. So for this patient, I had to use the posterior pathway. So the posterior pathway involves clearing the trunk, and then you start at the back of the neck, trying to move the fluid down. And then you have to bring all of this fluid, you have to clear up all the way around the ears, and then finally get to that submental region, which is usually bothering them. So the posterior pathway indications for this would be a neck dissection. So they usually have an incision. So that incision, a lot of those lymphatics aren't draining through from their neck dissection. So this is the most beneficial pathway to use for these patients. So this patient did have radiation and a neck dissection. So I had to use the posterior pathway when I was doing CDT with this patient. This is a tool that we use in our clinic. It is called the Lymphatouch. It uses negative pressure to help move some of that fluid. This is really helpful. I use this more with my head and neck patients than I do with any other limbs, because of that firm fibrotic tissue. It can kind of help break up some of that swelling. I did use this with this patient. So for his compression, he was really firm and pitting at first. So I used a foam chip bag. It was much smaller than this, and a compression bandage to start. After he became softer and it wasn't pitting as much, we switched to more a flattening pad with a compressive bandage. So I usually start with some of these options that I can make in clinic and get some buy-in with the patients. So if these compression is working, then I do suggest some over-the-counter things that they could buy online, stuff like that. And then we did try this FlexiTouch device with this patient, but he didn't like it very well, so he did not end up getting one for home use. So these were this patient's pre and post measurements. So he did show some improvement through CDT, but nothing significant. We didn't get that 2% change. We were pretty close, but nothing really changed. And this patient did come to me for one round of CDT, and then about a year later, he came back. He was softer, but his tissue was still just feeling firm, but it wasn't feeling fluid-like. So we did do a couple more sessions, and then it wasn't really helping. So I reached out to his surgeon and got him a referral to plastic surgery and was able to get him to Dr. Skoracki. He was really unhappy with how his submental region was looking. And I don't think this patient qualified for any of the lymphatic surgeries, but Dr. Skoracki was still able to help him out with some Kybella injections, I believe. So that is my story of like how my part of this head and neck lymphedema management. So we will let Dr. Skoracki talk about his. And like they said, if you have any questions, go ahead and put them in the Q&A and we'll be able to answer those at the end.
Thank you, Brittany. Thank you so very much. I just want to reiterate, first of all, that this is incredibly a multidisciplinary, this is a team sport, care of the lymphedema patient. And it takes a large team. And I think that I'm so glad Brittany could join us today, because none of what I can do, I think, is nearly as meaningful without a certified lymphedema therapist. And I think it's very much, we communicate multiple times a day often. And I think it just is absolutely all important. It's all important that there are many members of the team and that you have a very, very close and great working relationship with your therapists. I think otherwise none of the surgical options that I'll be talking about in a minute are nearly as meaningful as they can be. Before I get started, I just wanted to also say there are a couple of things in the question and answer. I think some of them we can maybe address right quick. One of the questions, and Brittany, I will ask you this one because I don't know. One of the questions was, do you use Comprelin when you're making, I guess, specific or patient individualized garments or any of these compression devices that you manufacture in clinic?
I don't use that specifically, but that could be really good because it's like channeled, so you can kind of put it in an area to help direct where you want it to go. So that could work. A lot of times compression is kind of a trial and error. I always have the patient bring it back so I can readjust it or change it as needed. So as they're going through CDT, what worked at the beginning doesn't always continue to work towards the end. So just make sure that you're flexible with your compression options and always educating the patient on how best to change it when they need to as well. But yeah, that could be a really good option with that channeling to direct it to where you want it to drain.
Thank you, Brittany. I'm going to share my screen now, and I've seen some of the other questions and answers, and so I will try to address some of the ones that have already come in during my talk. And if I don't satisfy, if the answer is not entirely satisfactory to you, then please follow up with an additional question. I'm just going to run through these slides right quick, just because I had stitched them together for Brittany and myself, and I'll get to my portion. While I do this, I want to talk a little bit about the assessment, and I think that's actually very, very complex, and it's very difficult in the head and neck, in the sense that there really isn't a tool that's out there that's been validated, as Brittany mentioned. And so I think Brad Smith, who did a ton of work in this space, was one of the kind of the first to come up with that measurement scale. We've since then, and with Brad actually, we've looked at 3D imaging and subtracting 3D volumes for the patient population that he had actually measured and had used in his study, where he came up with that with the tape measures. And unfortunately, we found that the tape measures are not accurate, and they don't predict volume in the way that we had hoped that they would. And so we're actually working on publishing that data. So we really do need a new way of assessing head and neck lymphedema, because it's so much more complicated in terms of volume assessment than the limb is. We are working on a 3D tool that will hopefully allow us to measure lymphedema for the head and neck and longitudinally measure it, so we can compare one measurement to the next and see what the actual volume difference is in the head and neck. And we've gone through initial phases of validating, and it's been very, very reliable so far, but we're kind of moving on into further testing, and hopefully we'll be able to have something that's available to really everybody within a short while. One of the questions actually was what causes head and neck lymphedema, and somebody was wondering if you can get a head and neck lymphedema after a dental procedure. Generally speaking, it's not any single intervention. It's usually a combination of interventions. And part of that is because, as Brittany mentioned, we have so much redundancy built into the head and neck in terms of the lymphatic drainage. And there's so many lymph nodes and so many lymphatic channels that can kind of take over for regions. And that's why head and neck lymphedema, functionally significant head and neck lymphedema, is actually relatively rare. Especially long-term, in that much of it often resolves. And so in my experience, really the more debilitating lymphedema of the head and neck is in those patients that have had significant removal of lymphatic basins. So a full neck dissection, unilateral, or even worse so in bilateral, and usually in combination with radiation therapy. And the two often go hand in hand, just because if you have metastatic disease to your lymph nodes, very frequently radiation therapy will be thrown into the treatment mix. And the combination of those two certainly increase the risk very, very significantly. Occasionally, we do find lymphedema in patients even preoperatively, where the tumor itself has significantly is significantly involving the lymphatic system and has already damaged the drainage pathways to a significant degree. And that patient is particularly at high risk because any of the other therapies that we deliver, including chemo, radiation, and also surgery, will further damage that system. And if you imagine if part of the lymphatic system is replaced by tumor already, and the tumor is sensitive to some of these treatments, as a side effect, any of the channels, any of the nodes that are involved with tumor that will respond to the other therapy will end up with a scarred dysfunctional system as well. So a simple dental procedure, while I would say is probably not impossible given the right setting, in the sense that somebody may already have a degree of primary lymphedema, and that's another question that was sent in earlier. So if there is already some damage to the underlying lymphatic system, certainly smaller things can set it off, but it would be extraordinarily unusual. Usually lymphedema in the head and neck is seen with a more significant intervention on the lymphatic system, with multiple modalities as being utilized. The treatment options then, as Brittany already told us, were obviously the conservative management that can be often very, very effective. And in the head and neck, it's one of those regions, unlike the extremities, where we see patients actually improve with MLD and have sustained improvement, that it's not a kind of a recurrence of fluid that accumulates, but this can be curative in a good portion of patients if they undergo the MLD and compression early on. For those patients that fail, I will talk about the surgical management as well and what we have available. I just wanted to reiterate this. This is incredibly important. This is, I think, that we may notice the external swelling on a patient, and that can usually, it involves kind of the central neck and submandibular, kind of the submental region. But it also usually is the lower cheek region. So I call it a little bit of the chipmunk cheeks, that they are significantly fuller, the lower third of the outer face. But in severe cases, that can ascend into the periorbital region as well. And I've seen a number of patients that have had that their swelling was so significant that they actually on bad days would lose sight, and just simply because their eyelids would swell shut, not unlike someone with terrible allergies, for example. But that's only the tip of the iceberg, in that the more importantly, functionally often is the internal swelling. And our colleagues at Vanderbilt have done a tremendous amount of work on this, and that goes actually on one of the other questions was about endoscopy. And for the internal swelling, it's absolutely important that be assessed endoscopically. And ideally, it would be nice to have a pre and a post-op endoscopic assessment, because it can be quite different. Sometimes subtle changes will make a significant difference because there's so little space. And we see some of these symptoms that have been reported, then many of them are related to the internal swelling, and that may be difficulty with speech and swallowing and drooling. airway concerns and thankfully a small portion of patients, but obviously extremely significant. And then that can also affect, as I said, speech. But then the obstruction of vision tends to be more the external lymphedema. Discomfort, tightness, that can often be very, very difficult to tease apart, what role lymphedema plays and what role just the adjuvant therapy that the patient has received in addition to the surgery. But the chemo and radiation will certainly increase that tightness sensation as well. One way of differentiating that obviously is just then to go through a course of MLD, and if much of the tightness is relieved, then that the remaining tightness is maybe due to the other treatment effects, but the one that is relieved with removal of the fluid is probably due to the lymphedema. And Brittany talked to this already, is that so there are certainly some patients that will go on to have prolonged lymphedema. Thankfully, a very significant number of patients will improve and will have some sustained improvement, and improvement that will not require as an intensive a therapy in an ongoing fashion as the extremities would. One of the things that in my mind is really interesting, and it's something that we're looking into right now and studying, is that there has been some data, and it's fairly good data, to suggest that the prolonged swelling of the head and neck is actually a poor prognostic indicator. And this is in cancer patients, obviously squamous cell cancer patients, that the prolonged swelling is an indicator of a poor prognosis in the long term, with higher risk of recurrence of the tumor, independent of the usual, the TNM, the tumor and metastatic disease indicators, which we know will have will be indicators of poor outcome. But the prolonged swelling itself also had one, and nobody has really explained the biology behind that. We do have some ideas, but at this stage, as I said, there's a lot of investigation going into this, because the hope is that we can change that. We can improve the oncologic outcome of a patient by intervening early with appropriate lymphedema care as well. So dive into surgical management of head and neck lymphedema. As I said, the majority of patients will improve on their own with or without the CDT and compression therapy, thankfully. But then there are a group of patients that will continue to have swelling, and that will be relatively recalcitrant. And Brittany gave us a great case example of that. So when do we consider surgical treatment for patients? It's really when the patient has either plateaued at a level where they're dissatisfied, or are progressing in spite of adherence to the CDT and to the work with their lymphedema certified therapists. And so, not unlike elsewhere in the body, what are the options for surgical management? It's the lymphovenous bypass procedures, vascularized lymph node transfers, and also liposuction, or some form of fat removal that we can offer those patients. And that obviously needs to be very much individualized, and we'll talk about that as we go along here. What's important, and Brittany alluded to this, is that there are other reasons for head and neck swelling that we need to try to figure out that this is truly lymphedema. And that initial perioperative swelling that's just expected is certainly not lymphedema, but will usually improve on its own. And some people say it should be gone within 2 to 3 weeks, and I think that's probably aggressive and probably hopeful. I think true perioperative swelling will last up to 3 or even 3 months or even longer, depending on the site in the body. And so I think that to call something lymphedema before 3 months from the initial therapy, I think is a little bit challenging, especially in the absence of any kind of CDT or MLD intervention. So outcomes, obviously, most of the time we have a fairly good reason for the lymphedema, and that goes back to the question that was answered earlier. If you had a tooth extraction and have swelling postoperatively, that's unlikely to be lymphedema. I would be more worried about an infection or something like that if it is prolonged. But if on the other hand, there's been a significant removal of lymph nodes plus radiation, or in addition, maybe even chemotherapy, then we have a very good reason for the swelling, and it may well be lymphedema. There's there's an absolute interplay between the lymphatic system and the vascular system. If the venous outflow is disrupted in any area of the body, that goes for the extremity as well, then we see much higher ultrafiltration rates, much higher rates of lymphatic production, and that may overwhelm the system. So an occluded or partially occluded venous outflow will certainly have a negative effect on the swelling, and that is something that should be addressed separately, and ideally before any type of lymphatic surgery is entertained. Icg lymphogram, just like anywhere else in the body, is an incredible tool for us to kind of see what's going on and to stage what's happening underneath the skin. So for us, the Icg lymphogram is really a way to delineate the presence of lymphatic channels, hopefully, because that would give us an option for lymphovenous bypasses, but also to give us an idea of the stage of the lymphatic function or dysfunction, as it may be. And then there are certain backflow patterns that show us actually very early disease that may be evident before we see it clinically, before we actually notice that there's significant volume change or pitting edema. And here's an example of an Icg lymphogram being performed where we inject a very small aliquot, usually 0.1 cc intradermally of indocyanine in green. This is a dye that binds to the protein molecules in the interstitial fluid, and the lymphatic kind of the floating around fluid in between the cells with the protein molecules, and we can monitor that under a near infrared light to kind of show us where that fluid goes. And what you're seeing here is this is dermal reflux. This is kind of the deeper lymphatics are refluxing. This is a deeper lymphatic right here in the nasogenital trough here, right between the eye and the nose. And you can see with the pen there, you can see how I can move that fluid along in a channel that seems to be reasonably functional still. But that spider web kind of lymphatic channels that you saw earlier, and I'll go back for just a second, and that represents, see if I can pause it on that for us here. That represents what we would call, what we consider dermal reflux, where the lymphatics within the dermis are filling up rather than the fluid being moved away in the deeper lymphatics that would usually clear that area. The dye actually refluxes into the skin, finds the path of least resistance, but that's actually in the wrong direction. And that gives us an idea that there is very significant damage to the lymphatic system. And here you can see that here are some of those pictures on the left bottom here. You can see there was that lymphatic channel, but it refluxed into the skin. So that's not one that's actually clearing the fluid very well. And this is a patient that had undergone bilateral neck dissections and had a preoperative radiation, chemo and radiation therapy. And you can see that he had a pretty significant lymphedema to that lower half of his face. And one thing that I didn't mention, actually, just looking at the ear canal there, is the swelling in the ear canal can get so significant that the patient actually has hearing loss with this as well. Here's just the other side, and here are some of the outlined areas where we were planning to do a bypass, where we had found some lymphatic channels that were still functional, where we felt that we could make a connection between the lymphatic system and the venous system, and to try to shunt the fluid from the lymphatic system into the venous system in the head and neck, rather than having to go through that scarred neck region where we know that there has been a lot of damage. And so here are just kind of some additional patients with some of the other patterns. It's not unusual that we see some lymphatic channels that wrap around the mentum, around the chin pad. There's usually something in that nasojugal trough between the eye and the cheek and the nose here. There's usually a lymphatic channel. Then there's usually one that runs over the brow and goes into the kind of the region in front of the ear, the temporal and pre-auricular region. And those are usually the areas that we look for first and see if there are any channels that we can tap into and that we could siphon that fluid off and give it a new pathway out of the head and neck region. This is a great study, and this is not specific to the head and neck. This has been, the study has been repeated for upper and lower extremity though, and it's interesting in that some of those channels, what I showed you there, the Icg injections on the left-hand side, we see these normal patterns that you would see on a limb where it just moves along and the lymphatics themselves contract and they move the lymph fluid along. If we start to see some damage to the lymphatic system, we see this next pattern, which has been termed the splash pattern. And then you can go to the right there. The further damage to the lymphatic system, you see kind of worsening into the stardust and then a diffuse pattern that you see on the Icg injection. What's interesting is that patients that have a linear pattern without any dermal reflux don't usually have any clinical indication of lymphedema, meaning there's no appreciable or measurable swelling and there's no usual pitting edema. The folks in the splash pattern can have some of those things, and usually in that stardust on the right-hand side of that red line, usually there is significant clinical lymphedema that's already been identified even without the Icg injection. Now that splash pattern on the left-hand side can go either way. Patients have been shown to revert back to a normal lymphatic function, or they've also been shown to go into the other direction, and we don't know who will do what. But the splash pattern offers us an opportunity to monitor patients with the Icg injections. If they're not don't have clinical significant lymphedema, there's not necessarily a need to intervene. However, it may be our opportunity to intervene before they convert into that stardust and then tend to worsen from there without any improvement. Certainly folks that are in that stardust pattern, even if they don't have significant external swelling or pitting edema yet, will usually worsen. They don't go the other direction. So that red line is really the cutoff point to intervene and to consider an intervention, certainly surgical intervention as well. So let's talk a little bit about lymphovenous bypasses. So that I believe that this was the patient that I showed you the pictures of and the Icg injections. This is kind of the plan that we had, and this is what we did on the left-hand side. And on the right-hand side, the pictures, as you can see, some of that we drew in blue ink there where the pattern of reflux was, and then also that line in front of the ear where we found a really nice lymphatic channel. And when we explored that area surgically, we were able to hook up that lymphatic channel into a venule. You can see there that also shows the sizes of these lymphatic channels. The lymphatic itself was 0.2 millimeters in diameter, and the venule that we found, a little blood vessel in the area, was 0.5 millimeters. And so we connected those two in an end-to-side fashion, still allowing fluid to go in the lymphatic channel, but essentially creating almost like a pop-off valve where the lymphatic fluid could find the path of least resistance, hopefully into the venous system, to remove the fluid and dump the fluid into the venous system and clear it that way. Similarly, in the kind of nasojugal trough here, we did actually nasolabial crease area. We did a side-to-side connection where we connected the lymphatic into a venule, again creating kind of this pop-off valve where it could drain into the venous system as well. And this is what this looks like under the operating microscope when we do the surgery. These incisions are usually about an inch in length. They're tiny little incisions. You can see these are the lymphatic channels there. The squares on that green background that you see, they're 1 millimeter in length. And so these are extremely small structures, very challenging. Thankfully, we have wonderful instrument makers, and we have amazing microscopes now that allow us to do some of this work and put these extremely small channels together. And here's just an example of a patient. This was the patient that we did that lymphovenous bypass. And I think what's very, very important always when you assess your patients, and this was still, we used the tape measure. And unfortunately, as I mentioned to you, the tape measure is not really that valid or not really that useful because you can see significant decreases in the tape measure while the overall volume doesn't really change. So very important is also to look at the patient's weight. So if the patient loses a significant amount of weight overall, you expect that they will also have a significant loss in volume in their head and neck region in spite of the lymphedema. And so we certainly can't take any credit for that. But if you look at that, he lost a significant amount of weight, an 11% weight loss before the surgical intervention. And he did lose only about 4% in his head and neck volume. And then with the surgical intervention, the lymphovenous bypass, within 6 weeks of that, the patient lost an additional 4% of his head and neck volume. And you can see in the pictures there, certainly as I call it, these chipmunk cheeks, the lower face, I think, is a pretty good indicator of where he's going. And that continued to improve. More importantly, probably for the head and neck is just the functional outcomes. If the patients tell us that, my swallowing, my speech is better, my breathing is easier, those types of things, and I can see better, I feel that there's less tightness, that's probably at this stage, until we have better volume measurements, is probably as good a measure, if not a better measure than any. Similar kind of idea, different type of surgery, but also previous radiation then required re-resection and then re-irradiation in this patient. And you can see there, about a week after the lymphovenous bypass already, while his weight maintained or remained stable, is the change in the overall volume of the head and neck just with these bypasses. And usually we are able to only find one or two. So a very significant reduction with in spite of just these tiny little channels being connected. What about what does this do on a kind of a microscopic level? Are we making a change? We can see a change in the overall volumes, but what about microscopically? Are we moving the needle at all? Are we changing this disease? Bhavik Marera from Sloan Kettering did a beautiful study, and we were lucky to be part of this, is where we actually took skin biopsy samples of patients before and after lymphovenous bypass and compared them to areas where there was no lymphedema. And we found in that study that 83% had symptomatic improvement. But what was really exciting is that there were actually changes in the skin. And in the area underneath the skin. And I won't bore you with all the details, but the kind of the quick and dirty is that there was actually decreased inflammation. There were markers of inflammation that we can test for on a microscopic level, and there were decreased markers of inflammation. The process didn't go back to the normal, so they weren't exactly like the normal side. But there was significant improvement in inflammation. Similarly, fibrosis, and that's part of the disease, obviously, with lymphedema, that scar tissue forms, especially over time. And the same thing happened here, that the markers that are kind of indicators of fibrosis, of scar tissue forming, were significantly decreased again with after the lymphovenous bypass. So we know that we're moving the needle not only in terms of the overall volume, but we're also changing the biology of the disease. And then finally, the thickening of the dermis itself and the increase that we see, the swelling of the capillary vessels in the subcutaneous tissues, which is really a function of the pressure of the lymphatic system, all significantly improved with the lymphovenous bypasses. Moving on into vascularized lymph node transfer, I'm just going to check the time. We have a little bit of time left. This is something, if we don't find any lymphatic channels that we feel are candidates for bypasses, or if we find that the patients just have just this generalized dermal reflux pattern where we find lots and lots of lymphatic channels that are immediately under the skin, but none that are really functional lymphatics that would be candidates for bypasses. In that case, we certainly talk about or offer a vascularized lymph node transplant. And here's a little bit of a kind of a patient that's very kind of the common appearance where the neck is extremely scarred, and then you see the very, very significant edema. In this patient's case, it even involved the periorbital, kind of the region of the upper and lower eyelids, making it difficult for the patient on bad days to see out of his eyes. And so for his injection here, you can see we injected kind of the similar type spots. There was one channel there in the nasojugal trough on him that looked promising. And I think we explored that, but didn't find anything there that could be bypassed. But you can see there's lots of this dermal reflux. And some of it actually is kind of pooling above the scar, as Brittany mentioned earlier. Interestingly, on him, we actually found one channel that crossed the scar. And so we did not want to interfere with that channel. You can see it there on the bottom right, where it goes across the neck scar into the chest. So that was the channel that we absolutely wanted to leave intact because it already had reformed. And here is kind of just an artist's rendering. That was Hiroswamy, I think, who made these beautiful drawings for me, where that functional channel, we wanted to leave that intact. And we thought that we might even see a low level lymph node on him that it went to, but then lots of dermal backflow elsewhere. So in this patient, what we did is we took lymph nodes and we took a lymph node packet from inside his abdomen and transplanted those to the head and neck. Now that takes a little bit longer. The recovery there is not as instantaneous in the sense that those lymphatics need to reconnect to the lymphatics in the head and neck and slowly kind of act as a sponge and absorb some of that fluid. And you can see here that at 4 months, he continues to have an improvement. Now, interestingly enough, the volume change actually went up after the surgery, and that is because the flap itself, the tissue that we transplanted, increases some volume. But if you look at the upper face, certainly around his eyes and also the cheeks, there's a significant improvement, and he did not change his weight, his overall weight at all. So again, I think at this stage, without being able to kind of specifically target certain areas for volume measurements, I think we rely very heavily on the patient's own symptom improvements, and that reigns probably more important than the volume measurements, because we just don't have the appropriate tools quite yet. What about liposuction? It's something that we certainly employ in the extremities, and we can absolutely utilize that in the head and neck as well. Now, I think you have to be very careful, because some of the patients have, if they have uncontrolled swelling still, meaning that there's still a lot of fluid and pitting edema, especially in that submental area where most people complain about the swelling, the liposuction is going to do very little for that area. It'll improve it significantly temporarily, but in the long term, that will fill with fluid again. So it's a great intervention for those patients that have mostly excess fatty deposits in this area. And that's certainly something that we've seen, and nobody has, I guess, demonstrated it better than Hakan Brorsen, for example, where we see that there is significant excess hypertrophy or enlargement of the fat in an area of lymphedema. And that happens usually over time. But if we see that, and if we can identify that as fat, and the way to do it is just on physical examination, and that there is no pitting edema left, but there is just an excess in volume in this area, and you can see that's very well defined, that pocket of volume, then liposuction can be an extremely powerful tool, because it's very effective at removing that fat. And we know, again, from the work that Hakan's done with 20 plus year follow-up now, that is a sustained improvement, that those fat cells don't regrow, that they maintain their volume in the long term, given appropriate compression in the extremities, but in the head and neck, if necessary, often less necessary. And here are just some examples from a publication out of the Head and Neck Journal, and this is kind of the types of results that we see as well. So in conclusion, and surgical treatment of lymphedema in the head and neck shows, I think, much promise and symptom relief. It's a difficult problem, and there are patients that have obviously undergone very significant other therapies already, and usually including very significant surgery as well. I find the patients, especially for lymphovenous bypass, that are probably the most challenging are those that have not undergone surgery, but just have undergone radiation alone, chemoradiation therapy. And part of that is probably, in my mind, that the lymphatic system was very significantly involved with the initial tumor in those patients. And they responded well to the chemoradiation, But that means that the chemoradiation also damaged the lymphatics that were already involved with the tumor. And so in the absence of any kind of functional lymphatic, it's very difficult to consider the patient for lymphovenous bypass. And then more often than not, do we have to move to a vascularized lymph node transplant? And even that, if we can't get the lymph nodes into the right areas, the patients don't show as much response, I think, as some of the patients that have undergone surgical resection, plus or minus radiation then. We obviously need a ton more research. I think it's still a very underdiagnosed form of lymphedema. And we are certainly doing a number of research studies in this area currently ongoing, but there are other centers, and I kind of refer back to Vanderbilt as well. They've done a ton of work in this and do some amazing work with specifically head and neck lymphedema patients. And there are certainly some other centers, and I would again refer everybody to the LE&RN centers of excellence around the country that will be very familiar with this as well. This is probably less important to this audience, but if there are any surgeons, I'm certainly happy to share some of the billing codes, because that can be a real difficulty also for patients if the insurance companies, many insurance companies will still consider this experimental. And so it's very important to us to kind of share our research and show that there's a very significant improvement in a very good number of patients, to kind of educate the insurers as well as to the utility of this, and certainly the very significant impact on quality of life for their clients. Challenges, I think education continues to be a challenge in the sense that I think lymphedema still is a little bit of an orphan disease. It's not as well understood, as widely as well understood as we would like it to be. And the head and neck especially, I think it's been an even more difficult, I think, nut to crack, in the senses that the treatment changes that we expect with the head and neck outside of lymphedema can often overlap and mimic the lymphedema. So it tends to be very difficult to kind of tease those apart, because it tends to be the same organ. Whereas in breast cancer, for example, the arm is not affected with breast cancer, but it's a side effect of the treatment there. The swelling, it's a little bit easier to assess that anatomic region. We absolutely need more and better assessment tools. As I said, we're doing some research into 3D imaging and apps that we can deploy that can actually be used on regular phones and iPads now, on tablets. This is really brand agnostic, thankfully. But the cameras that are embedded in these devices now, that the ones that allow you to have facial recognition to open the phones or the tablets, they're actually the cameras that can be used for 3D analysis as well, because that's essentially what that camera does, is it analyzes the three-dimensional structure of the person looking at it. So we've been able to do some really nice work in terms of utilizing these tools that are available and creating apps that allow us to measure head and neck lymphedema specifically. Earlier identifications of patients is so incredibly important, because, as I mentioned, the non-surgical treatment of lymphedema can be curative, and then also to be able to shuttle those patients or shunt those patients into the surgical treatment arm if necessary. We still don't know exactly who should receive lymphovenous bypass first versus a vascularized lymph node transplant, or combinations, as we've done in some patients. But we're continuing to kind of refine the roles of each of those. I think the role of liposuction is while very powerful, it needs to be clearly defined and identified, in the sense that the fluid component certainly responds to the liposuction in the short term, but does not respond to it in the long term. And so we don't want to expose patients to unnecessary surgeries that will not improve the swelling in the long term significantly. And then, as I mentioned, insurance coverage, again, is part of education of everybody to understand this disease better. So that concludes our talk. I'm going to go quickly and look at the chat and question and answer section and see. I'll ask Brittany to come back online if she can, and we'll go through these together. My email address is up there as well. Please feel free to reach out if you have any questions, if I don't get to all of the questions, and I'm happy to send them to Brittany as well, if there are some that I feel ill-equipped to answer.
I'll start, because a few at the beginning were questions more for me. So one of them says, do you ever use Kinesio tape as well for drainage? I have used it in the past. There's not a ton of research studies that say it has that much improvement. So sometimes if the other forms of compression aren't working, I will use that as well. And do I have patients sleep with a wedge? I don't necessarily have them sleep with the wedge, but if they're talking about not being able to sleep because they're feeling full, I will suggest sleeping on an incline. With flattening pads, what do you use? Short stretch, ACE, isoband. I usually use the short stretch to start. And then if people are compliant with compression, sometimes I'll suggest over-the-counter ones for purchase or even custom compression. The next question is, how do you treat internal swelling as a CLT? And they said that they use the Flexi Touch, and why specifically did my patient not like it? My patient did not like it because he felt claustrophobic in it because of the vest component and the head component. And then another barrier to using the Flexi Touch I have a lot is insurance coverage with my patients. And then for internal lymphedema, I don't do much of that, and there's not a lot of research out there with what can improve that. So I know Flexi Touch subjectively, some patients report being able to swallow a little easier after, but there really hasn't been much to prove that.
I want to throw out there, I think that MLD certainly has been shown, and I think anytime you decongest any area in the head and neck, I mean, everything is in such close proximity, so any decongestion you can do, I think will affect not only external but also the internal swelling positively.
Yes. That's usually the education I provide for my patients as well. I think those were a lot of them that were directed towards me, Dr. Skoracki.
And I'm happy to kind of address at the very top then a couple of primary lymphedema questions I'm just seeing. So there's one patient that is asking, is there any testing? There absolutely is. I mean, I think that, imaging will certainly show edema, and MRI imaging will show swelling of the skin specifically, but then the scope exam that was mentioned earlier is something that if you're having head and neck lymphedema is something that's absolutely valuable. To rule out, and you can see, I mean, swelling around the vocal cords, for example, and things like that, they're not that subtle, they're easily picked up. So the scope exam, probably if you're having speech, swallow type of symptoms would be absolutely something I would recommend. And that should be done, any kind of ENT that's familiar with scope exams should be very savvy and should be able to do those things for you. I'll just say another note in regard to the other person who asked about primary lymphedema. We would say yes, the initial treatment would be the same. The primary lymphedema is difficult because we often don't know exactly why it's happening. If it's a relative absence of lymphatic channels, is it a relative absence or a low number of lymph nodes? Or is it a valvular issue where the valves that are allowing fluid to move in a unidirectional fashion, so kind of being collected from areas and then being shunted into the lymph node basins, where some of that, or the majority of that fluid, is actually returned to the circulatory system, to the bloodstream again. Without those valves, it can go in both directions. You certainly see lymphedema. So it's not always the same problem, unfortunately. So it makes it really challenging, but we would apply many of the same tools and certainly some of the same investigations that can help us sort those things out. Father, no, oral cancer with radiation 2 exercise compression therapy not helping. Mid-Atlantic region. So certainly I think, and so maybe I'm stretching Mid-Atlantic, but so New York has a number of great centers. The group at Sloan Kettering is very, very savvy, obviously, with lymphedema in every part of the body. and would be great to work up the issue, and certainly do lymph node transplants as well. And I would absolutely seek them out. I think it's a great center. They do fantastic work and do a lot of research in this area as well, and would, I'm sure, be able to help. What are negative effects of swallowing and voice speech? So the things that we see that patients, I'm sorry, I didn't specifically kind of go into that, is we actually have patients that have difficulty swallowing, that literally cannot, with significant internal swelling, that can tell the difference between a good day or the beginning of a day and the end of a day, with swallowing, because they just cannot get the food bolus down, or they may have to drink a whole lot more fluid with the food bolus, or chew the food bolus smaller, or actually have a mechanically soft diet with a lot of fluid to try to move that food bolus down. So that would be an example of swallowing difficulties, and having maybe even to alter their dietary intake because of the difficulty with swallowing. Now, again, as I mentioned, that it can be very challenging to tease apart what's the dry mouth that goes along with radiation will also contribute to that, and so it will make that more difficult. Some of the scarring around the kind of the swallow mechanism may make swallowing more difficult also, and that may not be just lymphedema. It may be again the therapy, both radiation and surgery, and patients sometimes struggle with aspiration. So there's often, again, it's an area that has lots of function in a very, very small space. And it can be very significantly affected by all of the above, and lymphedema can certainly play a significant role. And voice and speech, it's often voice quality, voice volume can be affected. The resonance body, that is the mouth, obviously with swelling will change, so your voice quality will change as well with swelling, not just the vocal cords that create the vibration. So all of these parts can be significantly affected by lymphedema and by the swelling. Am I familiar with Reidner's group and the Vanderbilt? I think I referred to it a few times during the talk. Absolutely familiar. I mean, they do some amazing work, and they've shown they were the champions of showing us kind of the again, speech swallowing effects of the internal swelling. Yeah, I mean, they do some ongoing great work in this field, and again, a great center to seek out if you're having difficulty in that region of the country. If you already have a diagnosis of lipedema and lipolymphedema, does that make them more susceptible to head and neck? I have not seen that. I can't say for sure. I don't know of any data that's out there that would suggest that you're at higher risk of head and neck lymphedema because of lymphatic dysfunction that's been shown because of lipedema and lipolymphedema. To the best of my knowledge, in the patients that I've seen, that affects mostly the kind of extremities, lower extremity more than upper extremity, kind of hip, gluteal regions as well, can absolutely affect the upper extremities. Much more rarely the trunk, but I've not seen it in the head and neck region. Dysfunctional central lymphatics in the thoracic may cause confusion. Absolutely, and I think that's a great question. Is it kind of the cisterna chyli and the kind of the central lymphatics that are contributing? Probably, it may well be. I think that we have usually in the head and neck population, we have a pretty good anatomic location of when we know why the problem exists there, because we have the large nodal basins that have been resected and then and then usually radiated as well. So I think that the chest, while it may play and a role, is probably not quite as important. I think it's often the difficulty is getting the fluid down to the lower neck and upper chest region. But can we exclude it? Absolutely not. I think that we're scratching the surface. We're learning tons every day. So I think that I can't say for sure that there wouldn't be a dysfunction, but we certainly see it in the lower and upper extremities. That's for sure. Is lymphocentigraphy covered by insurance? Usually it is. And a head and neck lymphoscintigraphy is not something that's usually done. It's usually an Icg lymphogram that we perform for the head and neck, just because in the head and neck it's very difficult to perform lymphoscintigrams. But the Icg lymphograms are also usually covered by insurance. What else? Your stage 0 lymphedema is defined as disruption of the lymphatic system with minimal external. Do you see stage 0 head and neck cancer patients? We may, and that's the difficulty with stage 0 lymphedema that there may not be any external sign of, so we may see that in someone where we inject it for an Icg lymphogram, and we may see some of those early patterns of abnormal drainage, but that there actually isn't any external sign of it yet. I think that usually those patients don't come to see us, quite honestly, in the sense that the patients that Brittany sees, and we have an amazing group here, they often see patients preoperatively and then follow them postoperatively. So they have a wonderful way of kind of gauging what happened, to kind of what the patient's functional status was before any intervention and then after intervention. But generally speaking, those patients that don't present with significant symptoms, we usually send on their way, and obviously Brittany does a lot of teaching and kind of gives them a lot of information about what to look out for, but we don't necessarily see them, and certainly wouldn't expose them to an investigation unless there was a reason, because some of these, are not terribly uncomfortable, but are still uncomfortable. Internal lymphedema, I think we touched on that a little bit. There's nothing that we can do internally to relieve swelling or anything other than what we can do from the external side. And again, because the two systems are absolutely connected, or it's not really two systems, it's the same system, but it's just a function of swelling on both sides of the soft tissue wall. So anything we do to the outside will also have a positive effect on the inside. Esophageal narrowing over time for this patient population. The most recent literature indicating greater than 70 individuals developing head and neck lymphedema. Thoughts on more proactive systemic approach to lymphedema intervention? Great question. I think that we're obviously big fans of early intervention and trying to get to those patients and relieving that swelling as much as we absolutely can, and hopefully that we would see don't see those types of problems. So the esophageal swell, and it's difficult to tell because the narrowing obviously will happen with significant swelling in and of itself. It may not be esophageal narrowing requiring dilation, for example. It may just be swelling that is fluid, is literally lymphedema in the wall of the esophagus. And so I think, again, we're talking about the external treatment also positively affecting the internal treatment. The true esophageal narrowing, meaning having a stenotic segment, I think, again, it'll be very difficult to tease apart what's treatment effect, what's surgical and radiation treatment effect versus what's lymphedema effect. And I think they're a little bit different, is that a stenotic segment that responds to a dilation and maybe a stenting temporarily, I think is different than just swelling in the tissues. But that's a tough problem. It's a very tough problem. And it's a tough problem to tease apart. I have not used the Lymphatic. Is the Lymphatic camera, is that the one from Houston? Gosh, what's her name? I'm blanking. I think you're referring to the Icg camera. That's right now is not, I'm very familiar with the group. I've worked with them before, do amazing work. They have a beautiful camera that penetrates very deeply, much more deeply than some of the cameras that we have commercially available. But that camera is not commercially available yet. And we've reached out recently to find out where it's at. And I think they're still working on kind of commercializing that. But so I'm familiar with the camera. Some of my patients have undergone the imaging with this camera, but we don't have access to it, unfortunately. We know that patients often get better spontaneously. How do you know that surgical solutions are helpful? How do we do control studies? We wouldn't intervene surgically unless we had exhausted, first of all, given enough time frame. And if anybody continues to improve with the therapy that Brittany and her group provide, we wouldn't consider a surgical intervention. So we really would only consider a surgical intervention at a plateau stage or worsening in spite of excellent therapy. So I think that is kind of our control. We wouldn't. I mean, if somebody is continuing to show improvement, then I would delay their surgical intervention for sure. Primary lymphedema, lipedema. I'm working with a childhood tonsillectomy, could be causing head and neck lymphedema. Interesting question. Childhood tonsillectomy. I have not seen that. Is it possible? Essentially, it kind of goes back to the question earlier. If you have underlying lymphatic dysfunction, any kind of injury can certainly push that over the edge. The good news is with the tonsillectomy, you don't usually lose any neck lymph nodes. There's certainly lymphoid tissue that's removed, but probably not as important in drainage as the lymph nodes in the neck. So with the childhood tonsillectomy, unless it was done for a tumor, which I'm assuming it wasn't, then there would be no injury to the lymphatic system itself. So it would be unusual. I haven't heard of it, but again, not to say that can't happen. Insurance companies pay for this, very hit and miss. So it really depends on, Medicare has approved it for us on a case-by-case basis, but they tend to be the ones that we need to reach out to them ahead of time and kind of let them know what we're doing. And usually they say we don't give pre-authorization or pre-certification, but we have a reasonably good relationship with them. And so they usually give us some indication of if they will cover it or not. And other private payers, it's hit and miss. Some insurance companies are great. They definitely recognize this, and we try to send in every insurance company some educational material to kind of bring them up to speed as to where the latest in research is, so that hopefully they will incorporate this treatment into kind of their future discussions on coverage. Sentinel lymph node biopsy used in the head and neck patient. It is, and for certain tumors and certain cancer types, and it's very unusual to kind of do the question is will when dissecting lymph nodes, is sentinel lymph node biopsies used in the head and neck region? And yes, in select patients and select tumor types. And I think altogether we're being much more the maybe not sentinel nodes, but are doing more selective neck dissections, which means removing only portions of the nodal basins in one side of the neck rather than the entire kind of neck region. So there's an absolute there's an awareness of this issue, and there's an absolute attempt at trying to minimize removal of lymph nodes while still providing an oncologically sound operation. And there's lots of ongoing studies in terms of kind of trying to minimize the number of lymph nodes that are removed, and not unlike in the breast. Certainly in the breast, I mean, that, you know, is constantly trying to minimize the lymphedema risk. Same for the gynecologic cancers as well. How do we locate a surgeon in our region? I would refer you to the LE&RN website. They have an incredible wealth of knowledge on their websites. And they also highlight many of the centers that are savvy with that offer many of these services, but also you know, have been designated their centers of excellence. I think that there's some great therapists, great surgeons around the country that can help. On the patient examples that you showed, what is being their long-term recovery? Did swelling return? Generally speaking, so unfortunately in the head and neck, I have to say with many of these patients, the survival rate is not great, especially many of the ones that I showed you had already a recurrence after initial treatment, after initial radiation therapy. And they're the ones that are at highest risk, that are getting re-irradiated, have a second bout of surgery, for example. So overall long-term survival often tends to be very poor. So we don't have very long-term follow-ups. Now the patients, the ones that I showed you, did improve, and two of them passed away, unfortunately. but they did have sustained improvement until they passed away. Have you used the Hiva mat as they do in Europe, allows deep oscillating therapy? I have not. I'm going to ask Brittany, have you any experience with this? No,
we're not using that. And then the next question I can answer a little bit. Have you ever considered having patients wear pulse ox while asleep to identify their oxygen obstructive issues? No, I have not. Usually if they say that the swelling's affecting their breathing while sleeping, I'll refer back to the physician team so they can look at that.
And so I can answer that right quickly. I mean, anybody who has any kind of symptoms of sleep apnea or, kind of headaches in the morning, not restful sleep, multiple waking up episodes during the night, we would absolutely send them to our sleep therapists, and they will do exactly as you suggested, plus video, sleep lab studies and all this kind of stuff. So that's a great point, and absolutely should be referred, needs to be looked at very carefully, because that can be a very, very serious condition. You're absolutely right.
And then the last on the Lymphatic, yeah, I think it's an app that actually measures limb volume, but the last I looked into it, it was not doing head and neck, that Lymphatic camera and program. I don't know if whoever posted about that has any updates on that, but no, we're not using that here currently.
And I don't know. I mean, we have multiple 3D camera systems that we've used over the years, and I'm blanking right now. There's one was, oh my gosh, we're just trying to get rid of one right now. So there have been these 3D camera systems have been around for head and neck, for chest, for extremities, and they've been used for various reasons. But the Lymphatic I haven't used. Honestly, I think the cameras we have right now, the camera systems have become so sophisticated. The camera systems we can carry in our pockets have become so sophisticated. It's really now a matter of getting the software. And the difficulty is not capturing the 3D volume anymore. It's really capturing in a reliable way the cutoff points, especially in the head and neck. If you imagine kind of a change in hairstyle, if you're including the hairline, will completely change the volume. The point where you cut off at the neck region, you include a ½ centimeter in one direction or the other, will completely change the volume. So that software is probably going to be, I think, the key to the camera systems. Less so now. I think it's the software that will allow us to create reliable, reproducible cutting planes that will let us reproducibly measure the same patient multiple times. Facial hair, big problem in men, obviously, if they don't shave the same level from one measurement to the other, it almost invalidates the measurements. But lots and lots of different camera systems out there, 3D camera systems. But I think that the sophistication of the kind of the systems that we carry with us now, the camera system is actually so good already that it's just more of a matter of software challenges now. Anything else? I know we're way over time, but I appreciate everybody hanging in there. Thanks for the great discussion. Thanks for the wonderful for question and answer sessions here. I really appreciate that. Gives us good feedback as to what the thoughts are out there, what the challenges are out there with all of you. Thank you, Brittany, for being here again. We're very proud at Ohio State University. We have a very vibrant lymphedema center. We're very proud to be a LE&RN Center of Excellence. We'd love partnering with the LE&RN Network, who do such an incredible work, both in patient education, but insurance education and lobbying, and supporting all of us centers with grants and new and important data. So we're extremely thankful, extremely happy to partner with everybody at LE&RN. Thank you all for tuning in today. If you have any additional questions, please don't hesitate and reach out to us. Thanks so much.